Hello, everyone. Welcome back to Afternoon Tea with Docs, Friday with Dr. Sarmila, talking about mental health, stress management. Today is World Suicide Prevention Day, and our focus would be on how to recognize depression. We've been talking quite a bit about stress in the last few weeks, and we know that chronic stress can actually lead to depression. And before we go into that, I just want to share with you some alarming figures in the UK, actually, it being World Suicide Prevention Day. Actually, in the UK, 1 in 5 people in their lifetime will have some form of suicidal thoughts. And I think 1 in 15 people have attempted suicide in their lifetime. And these are figures according to Mind, the charity Mind. Does that reflect what you see in practice, Dr. Sinha?
Yes. Good morning, everyone. We see the more extreme end of the people of the population who come to us. Obviously, for us, people who present to us with severe depression or other mental health illness, the rate of experiencing suicidal thoughts are really high, but that doesn't reflect the general population. Obviously, we see the more severe end. I totally can understand and relate, particularly with the pandemic hitting us. I think the statistics of people feeling suicidal and feeling severely depressed have gone up.
Yeah, the pandemic definitely has impacted on people's mental health, and lots of anxiety out there, and the isolation, loneliness from staying at home throughout the lockdown, and changing people's perspective on what it is like to socialize. Has definitely impacted on people's mental health. Could you tell us a little bit about stress and how that can actually lead to depression?
So, stress is recognized as perpetrating and precipitating factor, a trigger for mental illnesses, and particularly with depression, anxiety. Suicide is linked with depression, when people are severely depressed. So depression is of 3 types: mild, moderate, and severe. So when somebody is experiencing suicidal thoughts, that's definitely a marker that they are severely depressed. Now, coming back to, stress and how it is linked with depression, I think when people are stressed initially, suicide is not linked with stress per se. They're not feeling suicidal. But if the stress is not addressed, if it can go, if people ignore the stress or it goes unnoticed, or they're not doing something about it, then it can lead to mental health problems, particularly depression, which can eventually, lead to experiencing suicidal thoughts. But I must say that suicide is not a common outcome of stress. It's not a common outcome of depression as well. A lot of people facing depression recover, they do very well. It's only a minority of the people. But saying that suicide, people did not have mental health problems. People can feel suicidal because of life circumstances driven by acute stress. So we've had statistics of people with no contact with mental health services whatsoever, and they end up committing suicide, which is really unfortunate.
Yeah, absolutely. And actually, talking about depression, we kind of use the word depression quite loosely in everyday conversation. And often people refer to low mood or feeling a bit blue or low as feeling depressed. So what is actually depression, and how can people recognize it other than feeling low in mood?
So depression is, I agree that low mood, feeling blue, These are the terms we use very loosely in our day-to-day lives, just to express how we are feeling. Even people experiencing stress can use these terms, But on a professional level, on a clinical level, if somebody comes to us feeling, then we go through a cluster of symptoms of what constitutes depression. So if somebody is experiencing not just low mood, but they have other symptoms with it, like changes in their biological rhythm, like changes in their appetite, changes in the sleep, feeling low energy levels, lack of motivation, and even not enjoying the things that they used to enjoy before. It's known as anhedonia, which means they're not deriving any pleasure from activities that they used to enjoy. And all of these symptoms, they need to be present for a minimum of at least 2 weeks to be classed as depression. So we do go through quite a checklist of things before we diagnose somebody with depression. But somebody can, loved ones can diagnose depression among their loved ones if they are suspecting it, to say that, they have not been the usual self, something has gone wrong. They probably can sense, and then they can also seek help at that stage. So it's important for people to understand what depression means and what the symptoms are. So as I said, changes in the sleep, changes in the appetite, changes in the personality. So they're more quieter, more isolated, not as outgoing or social as before, things like that. And some people actually use substances or alcohol to mask their symptoms of depression. So if somebody is not feeling like socializing, they can drink alcohol and they can mask their low mood and go out and socialize. But that doesn't mean that they are not depressed.
Yeah, and actually, there are some symptoms that people may not associate with depression, like being forgetful. Because of the lack of concentration, you then don't pay so much attention on the tasks and where you put things, and then you end up being forgetful. And people sometimes come to me saying, I'm worried about my memory, and I'm worried that I've got early dementia.
Yes.
But in fact, it's actually them being depressed that has led to this. Do you see this often?
Absolutely. Poor attention, poor concentration, it's also another important symptom. The cognitive deficit in depression is reversible, obviously, and we have to reassure them that, whatever you are experiencing is, just to reassure that. But it's also a good idea to do some tests, basic tests, particularly vitamin D levels, because thyroid levels, vitamin D levels, because they are also associated with depression. So as a GP, as you are a GP, and I think in your case, it's good that you have access to, you can just do the basic tests and rule out the other, differential diagnosis of depression. And then if they're all stable, if they're all fine, then obviously, think of depression. Dementia, with old age, people can experience memory problems. Obviously, the person presenting, because you see, depression is very common in the elderly population. It's more common in the elderly population compared to the working population. So again, it's a bit of a difficult situation, isn't it, where you to draw the line. So I guess maybe you can shed some light on how do you approach elderly people coming to you complaining of memory problems.
Yeah, I think we'll go into that in more detail on Sunday.
Okay.
We have a long chat with you on Sunday.
Yes.
On mental health in the elderly, and especially depression in the elderly population. And with it being World Suicide Prevention Day, and the figure that I mentioned earlier, and knowing that actually men are 3 times, although women are more likely to have suicidal thoughts and have and do self-harm, men are 3 times more likely to take their lives. What other suicide risk factors are there?
So the suicide risk factors, I think genetics plays an important role. When we take a history of depression, we always try to find out, has there been a history of suicide in the family? Because that is an important risk factor. Now, childhood adverse events is also another risk factor. Like if somebody has lost their attachment figure, it could be their parents, or losing their mom or a carer at an early age. That is a risk factor. And also general, there are lots of other factors like general day-to-day stresses or trauma, history of trauma, and poor coping skills. So if they don't have a good support network, if they're not having a good, social support network, then obviously the risk of suicide also increases. And misusing substances, abusing alcohol, alcohol dependence, these are also quite significant. And life situation, life circumstances, for instance, going through a significant life event like divorce or losing a job, or suddenly something has happened, or maybe a relationship has ended. We see when I was working as a trainee in A&E, I used to see a lot of cases of overdose come to A&E in the younger population, particularly among the female population, who have taken an overdose because of a relationship ended. Now, these people were not suicidal before, but just because there was a significant life event, like a relationship breakup, they did not know how to cope with it. And they felt getting out of the situation means ending their lives, and they took overdoses and things like that. So significant life events is also an important risk factor. And there are a lot of other risk factors. I mean, I think it's important to realize that, if you are experiencing stress, and if that stress is not addressed, if you're not getting the right help at the right time, things can deteriorate very quickly.
And I remember learning about this in medical school and throughout my training as well, that middle-aged male, especially the kind of 45 to 49-year-old group, they are at the highest risk of suicide. Why is that?
I think among the middle-aged population, I think there has to be, just being middle-aged is not the risk factor per se, but I think there has to be some significant event associated with it. Most of the men experiencing suicidal thoughts are either going through divorce, job loss, or loss of control of their lives. So something has happened. Or I have seen in that age group, people who have been caring for their parents or who have been caring for their loved ones and they lose their loved ones suddenly. Maybe they lose their parents and they then suddenly start feeling suicidal. And another big risk factor is very important in men as well, is experiencing any physical health problem. Like it could be a heart attack. It could be they've been suddenly diagnosed maybe with cancer or a significant physical illness, and they suddenly don't know how to cope, how to get away from this, and they start feeling suicidal. So physical illness is also linked with depression.
Okay, so and how can we how do we recognize these people around us and kind of reduce the risk of them proceeding to do something to hurt themselves?
I think the first port of contact, I mean, I think it's, if you're living with somebody and you're suspecting that that person is experiencing low mood, severely depressed, always a good idea to check. And particularly the warning bells should have arise. If somebody has a history of depression or recurrent depression, and they're not on medication, or somebody has got, say, bipolar illness or a mood disorder, and they've suddenly stopped their medication, and particularly very significant also among the the pregnant population, that where they have to stop medication just before, during the pregnancy, and then postpartum their risk escalates. So just being mindful of these issues around the patient. And the first port of contact is obviously the GP. And I think to have that connection with the GP is really important, because they're really, that is, people do feel that they can relate, they can express themselves because the GP knows them from before. But if it is an emergency, obviously, there are so many avenues to seek help. I always tell my patients, don't wait for the doctor. Don't wait until Monday morning to see your GP. Don't wait for 9 o'clock in the morning to book an appointment. If you're feeling suicidal, you need to act. And the first thing you can do is just dial 999. That's as simple as that. Just call somebody. If you don't have any number with you, and you can just remember that simple number. But there are other organizations like the Samaritans, and they have a number called 116123. It's available 24 hours. You can seek help. There is also the crisis team. Within the UK, every local area has got its own crisis team. And somebody who is already known to the mental health services, we always give them the number for crisis team, and they can seek help through them. And if they can come to A&E, get assessed by the doctors, it's also possible. But my advice is, don't sit at home. Don't wait for it to get over. Don't wait for the suicidal thoughts to get over. If you're feeling suicidal, you need to seek help straight away. Because the mind can play tricks with us, and people who feel suicidal just feel that they are on their own, feel very isolated, and therefore help is really important. And so there's a very important role for the carers, for people who are living with a person who is feeling suicidal, is to offer the support and offer the help.
And what you said earlier was something I picked up on, that they feel very alone. And actually, that's one thing I always tell my patients, that they're never alone. There's always somebody to call, like the numbers that you have mentioned.
Yeah.
And a note to all healthcare professionals out there, to really listen to the patients. I know we're all very, very busy at the moment, but it's so important for us to actually take that time to let them speak, and listen to their concerns, and hear what they have to say, and what's led them to this point. And sometimes saying certain things, like, your children need you, may not necessarily be the most helpful thing, because the patient may feel that actually them being out of the picture is the best thing for the children. And that this is feedback that I've had from speaking to somebody who has gone through a suicide attempt, and she reflected that actually people saying these comments to her was very, very unhelpful. Yeah. So just knowing, I guess, listening, is the only way we would know what our patients need from us. Yeah. And if we're unsure, ask.
Yeah, I'd just like to mention two things here, that we associate suicide with depression, but suicide can happen even if a patient has no mental illness. So a person who is completely fine, and it does happen, they plan the suicide, they write, they go through the will, they prepare the will, they talk to the solicitors, and they just plan the suicide really meticulously, and it has happened. That is number one, that suicide is not just related with mental illness. And the other thing is, suicide is also not just related with depression. People who have experienced psychotic episodes, it could be psychotic depression, but there are other psychotic illness like schizophrenia. So when the first year of recovery from schizophrenia is really, really crucial, because suddenly they realize that they have a mental illness and they have to live their life, the rest of their lives, with the mental illness. It's a big deal for them. And how do they cope with that? So people who are newly diagnosed with severe, significant mental illnesses, they're also at a higher risk. And saying that, even with people who are going through difficult physical health problems, things. So just we have to be aware that suicide is not something that is, you can put it with, it's not a sticker that you can just label it with some diagnosis. It can happen throughout the spectrum. And I would say every age group, it can happen in any age group. Unfortunately, with the elderly population, the risk is slightly a bit more higher. These are the two things I just wanted to.
Yeah, thank you for raising those points. We've gone quite a bit over time today. These were important things to talk about, and not just on World Suicide Prevention Day, but every day, to raise awareness of this. we'll go into a more detailed discussion about mental health, especially in the elderly, on Sunday, this Sunday at 5 o'clock at our usual afternoon tea with docs session. And so thank you for joining me today, Dr. Sarmila. And we will and for anyone who is interested, Dr. Sarmila Sinha has designed a stress management trainer course affiliated with the BSLM, British Society of Lifestyle Medicine, and we'll put the link down in the description. And the course is a one-day course starting on the 18th of September, so next Saturday. It's very soon, very exciting.
Yes, looking forward to it. Thank you so much. Thank you.
Thank you for joining us.